Good afternoon, ladies and gentlemen. I would like to express my thanks to GSK for organizing this scientific symposium addressing an important topic in oncology, which is the treatment of HER2-positive patients with breast cancer. Actually, treatment of breast cancer had a long way of hard work that paved the way for today's practice. We can see that sometimes flowers can emerge from hard rocks, and actually to have the flowers of hard work of several years, even a century, on breast cancer is a story of a great success. Actually, the last century had witnessed a great progress in treatment of breast cancer patients, starting from extensive radical surgery plus radiation therapy in the early 20s, and followed by the introduction of chemotherapy as well as hormonal therapy in the mid-40s. And with more time, chemotherapy had improved, endocrine therapy improved, and became major player in the treatment of breast cancer. And this had an impact on improving survival as well as increasing breast-sparing surgery. By the late 90s of that century, the dose-dense chemotherapy became available, and that helped us to do the so-called personalized tailored therapy for individual patients. The great achievement actually was at the end of the century and at the beginning of the millennium with the introduction of targeted therapy. Actually, we are all familiar with the challenge of HER2-positive disease, which occurs in about 25% of breast cancer patients and had an adverse impact on prognosis. This raises the importance of implicating targeted therapy in the treatment of HER2-positive breast cancer patients with a fair, acceptable safety profile with no serious adverse events and a high efficacy when combined with either chemotherapy, hormonal therapy agents, with improved results concerning survival and disease-free survival. But still, the situation is not so romantic because these drugs are still expensive, especially in developed countries. And even in some of the Western countries and Western Europe, it's still expensive. Trastuzumab, the famous and oldest targeted therapy involved in treatment of breast cancer. Trastuzumab targets type 2 epidermal growth factor receptors, amplified, as we mentioned, in 20 and up to 25% of patients. Trastuzumab was used initially for the treatment of metastatic breast cancer and achieved a great success, and then was shifted to the adjuvant setting, and as we all know, it became a standard of care in patients with HER2 amplification. But unlikely, there's a concern regarding cardiac toxicity of the drug. With the introduction of the second generation of targeted therapy, lapatinib played a new role. Lapatinib is an oral, small molecule tyrosine kinase inhibitor of both EGFR and HER2, and it's approved in combination with chemotherapy, mainly capecitabine, and in patients, of course, with HER2 positive who have progressed after trastuzumab, including therapy. And it's also approved as a first-line metastatic in addition to aromatase inhibitors in patients with HER2 positive, with hormone receptor positive as well as HER2 over-amplification. Generally, the major goals of treatment of patients with metastatic breast cancer are directed towards control of disease aggressiveness, maintenance of a good quality of life, and the improvement or even elimination of tumor-related symptoms, and hopefully improving survival. And to reach this goal, treatment should include systemic therapy, either endocrine, cytotoxic, and or biologic therapy, and some symptomatic control with drugs for pain, dyspnea, cachexia, to improve depression, to improve patients' quality of life. As regards to the biology of HER2-targeted agents, HER2 or ERB2 represents a family of 4 type receptor tyrosine kinases. They are important in human growth and development with similar structure, but ERB2 lacks ligand binding domain, while ERB3 lacks functional intracellular tyrosine kinase domain. This beautiful simplified diagram shows the harmony of the work of the ERB receptor family. ERB 1, 2, 3 are involved in cell cycle progression, proliferation, survival, as well as apoptosis, while ERB2 is concerned in cell differentiation. Multiple strategies could potentially be used to block signaling through ERB receptors. While all of these strategies could potentially be used to inhibit ERB receptors, so far monoclonal antibodies and small molecule tyrosine kinases have been studied in the clinical setting. Monoclonal antibodies block ligand binding or receptor dimerization, while small molecule kinase inhibitors inhibit phosphorylation and downstream signaling pathways. As we mentioned, lapatinib, the oral small molecule with dual function inhibiting both the ERB1 and the ERB2, has a unique mode of action that it works intracellularly, and we see later that had an impact on treatment outcome. As we mentioned, ERB2 actually is an independent risk factor that carries a poor prognosis. And we can see here the survival at 36 months for patients with ERB2 amplification more than 5 copies is about 40%, while for those carrying non-amplified receptors, the 36 months survival rises to about 85%. And actually, it's a big, significant difference. And that gives us an impact factor that we have to go aggressively for treatment of ERB2 positive patients with targeted therapy to improve the results. Data in these slides published 12 years ago and was one of the earliest studies demonstrating the efficacy of targeted therapy in the form of trastuzumab when added to paclitaxel. Actually, as we can see, there is a survival benefit in favor of trastuzumab containing therapy as compared to paclitaxel alone. Although this study was the first one to report the efficacy of trastuzumab containing therapy in metastatic breast cancer, and it was a retrospective one, but it paved the way for a battery of prospective randomized trials that approved the benefit of adding targeted therapy with trastuzumab and the other biologic agents to systemic therapy and its impact on improving overall survival as well as progression-free survival. This curve shows the benefit of what we called the intracellular activity, the unique specificity of the lapatinib. Lapatinib is active against tumors expressing P95 ERB2 variants. And this study published by Strategy and the colleagues has shown a significant decrease in tumor volume in patients harboring the P95 ERB2 variant compared with, when treated with lapatinib, compared, as we can see, to those treated with either trastuzumab or the control. To summarize the different aspects of lapatinib in comparison with the oldest targeted therapy, trastuzumab, we can see that lapatinib can be easily handled being an oral drug. It inhibits heterodimering signaling, and being a small molecular weight molecule, it can penetrate blood-brain barrier in a sufficient concentration that will be of great value in treating brain metastases. It has an inhibitory activity for the P95, and it has no impact on cardiac toxicity, and actually this gives a more acceptable toxicity profile for cardiac patients, and also this adds actually hope for further research on the drug and the other drugs to improve results of treatment. And finally, I would like to thank you for your attention, and I would like to introduce for the next session my colleague, Professor Tariq Hashim, Professor of Clinical Oncology at Montefiore University.
Thank you, Professor Ibsam, for this introduction. Actually, it's my pleasure to share this session with Professor Ibsam Sadeddin and Professor Osman Mansour. I will focus on the role of targeted therapy in the management of brain metastases in breast cancer patients. In patients with breast cancer, the development of CNS disease is a poor prognostic indicator, with only about 20% of patients surviving 1 year. It is estimated that 10 to 16% of women will develop CNS disease during the course of breast cancer, some of which is only apparent at autopsy. The development of brain metastasis can have a devastating impact on patients in the form of headache, changes in mental status, seizures, loss of coordination, nausea, and vomiting. Usually brain metastasis from breast cancer treated by whole brain radiotherapy. But unfortunately, even after successful therapy, patients may not return back to normal. The median survival for untreated patients with brain metastasis from breast cancer ranged between 5 to 7 weeks, with about 20% 1 year survival. But recently, when trastuzumab has emerged as a part of the treatment, the natural history has prolonged by more than 1 year. The risk factor for developing brain metastasis from breast cancer, including younger age, presence of visceral metastasis, lack of ER expression, basal-like phenotype, and ERB2 overexpression. The incidence of CNS metastasis as first site of relapse is significantly higher in patients with overexpression of ERB2 in comparison to those who do not carry ERB2 overexpression. 4.3% in the ERB2 overexpressed arm in comparison to less than 0.5% if ERB2 is not overexpressed. In addition, the association between ERB2 and CNS relapse, there appears to be a high incidence of CNS disease among patients who have received trastuzumab therapy. A retrospective analysis of various trials of trastuzumab have shown incidence of CNS disease ranging from 29% to 43%, compared with less than 20% in the general metastatic breast cancer population. In 3 major randomized trials evaluating the efficacy of trastuzumab in the adjuvant setting, the incidence of CNS disease as first relapse was higher in the trastuzumab arm when compared to the control arm. 12 versus 4 in the N9831 trial, and 21 versus 11 in the B31 trial, and 21 versus 15 in the HERA trial. The increased incidence in CNS metastasis rate can be justified by the fact that CNS disease is more common in ERB2 overexpressing breast cancer, and CNS metastases generally occur later in the course of the disease progression. Trastuzumab prolongs survival in patients with ERB2 overexpressing breast cancer, but because of its size, trastuzumab does not efficiently cross the blood-brain barrier. Therefore, the improvement in systemic control provided by the trastuzumab may paradoxically allow the intrinsic property of ERB2 overexpressing breast cancer to metastasize to brain. The currently available treatment for patients with brain metastasis include corticosteroid, whole brain radiotherapy, neurosurgery, stereotactic radiosurgery, and chemotherapy. There are few published data about the outcome of whole brain radiotherapy as a definitive, and when trastuzumab was part of the treatment, there is definitive improvement in terms of overall survival, 11% versus 7.5 or 6.5% when trastuzumab was not part of the treatment. There is a definite improvement in terms of overall survival, comparing the old series with the new series. In the old series, where when trastuzumab was not part of the treatment, the overall survival was about 6 months compared to more than 12 months if trastuzumab was part of the treatment. Despite the fact that whole brain radiotherapy can improve the outcome in patients with breast cancer, almost half of the patients will develop neurocognitive function decline during the first 4 months of treatment. On the other hand, brain metastases from breast cancer have been treated by upfront systemic therapy with an overall response rate ranging between 0% to 53%. This is a phase 2 trial of 242 patients with HER2-positive metastatic breast cancer and progressive CNS metastasis who had all been treated with prior whole brain radiotherapy or stereotactic radiosurgery. In the parent study, lapitanib was given in a dose of 1,500 milligrams per day, and patients who developed CNS disease progression were allowed to be enrolled in an extension arm. Almost 50 patients were included, and in this arm, patients received lapitanib in a dose of 1,250 milligrams per day, plus capecitabine, 2,000 milligrams per meter square per day from day 1 to day 14. The study objectives was CNS overall response, site of first progression, PFS, tolerability, and percentage of patients with more than or equal to 20% volumetric reduction in brain lesions. In the extension arm of this study, an overall response rate of 23% and a median time to progression of 62 months were achieved. In addition, L&C combination have shown notable activity in progressive brain metastasis after whole brain radiotherapy with CNS volumetric response rate of 20%, and the median time to progression of about 3.65 months. Part of the analysis of the EGF 100-151 trial was to see the incidence of symptomatic CNS metastasis as a first site of progression. It appears that lapitanib plus capecitabine reduced the risk of developing brain metastasis as compared to capecitabine, 2% versus 6%. This outcome represents a CNS metastasis prevention endpoint and not a CNS metastasis treatment endpoint. The previously presented data of the EGF studies, which confirmed the efficacy of LNC combination in the treatment of brain metastasis, in addition to the fact that upfront systemic treatment allows concomitant treatment of extra CNS disease, also it might delay the whole brain radiotherapy associated toxicity. These were the rationale of the landscape trial. The objective of this trial was to assess the efficacy of this combination on brain metastasis in HER2-positive patients who had not previously received radiotherapy. Eligible patient had HER2-positive metastatic breast cancer with brain metastasis not previously treated with whole brain radiotherapy, capecitabine or lapitanib. In this trial, patients received Tykerb in a dose of 1,250 milligram per day and Xeluda in a dose of 2,000 milligram per meter square per day from day 1 to day 14, every 21 days. The primary endpoint was a centrally assessed CNS objective response, defined as more than or equal to 50% volumetric reduction of CNS lesion in the absence of increasing steroid use, progressive neurologic symptoms, or progressive extra CNS. The secondary endpoints included time to progression for both CNS and extra CNS disease, as well as time to whole brain radiotherapy. This is the patient characteristics. The majority of patients included in this trial have at least one site of metastasis, excluding CNS, and more than 90% of the patients were previously treated with trastuzumab-based chemotherapy. Almost 69% of the patients included received trastuzumab in the metastatic setting. Looking at neurological symptoms at inclusion, there about 57% of the patients were suffering from neurological signs and symptoms at presentation, and headache was the most common neurological symptom and occurred in about 27% of the patients. 65% of the patients included achieved more than or equal to 50% CNS volumetric reduction, more than 80% reduction in 20% of the patients, and about 50 to 80% reduction in another 45% of the patients. The median time to progression was about 5.5 months, and time to progression was greater in patients who responded to treatment than those who did not respond to treatment. The overall survival at 6 months was 91%, and the median overall survival was 17 months. Grade 3 and grade 4 diarrhea and hand and foot syndrome were the most common adverse events occurred in about 20% of the patients included. The upfront lapitanib and capecitabine in patients with brain metastasis from HER2-positive metastatic breast cancer before whole brain radiotherapy can achieve an overall response rate of 67%, median time to progression of 5.5 months, and the median time to whole brain radiotherapy of 8.3 months. So LNC is an active treatment option and viable alternative to immediate whole brain radiotherapy for HER2-positive metastatic breast cancer patients with a newly diagnosed brain metastasis. The primary endpoint reflects the activity of lapitanib in combination with capecitabine in both CNS and extra CNS disease. The LEAP is a worldwide single-arm open-label study In this study included HER2-positive metastatic breast cancer patients who progressed after an anthracycline, taxanes, and trastuzumab. In this study, patients received capecitabine in a dose of 2,000 milligrams per meter square daily in 2 divided doses from day 1 to day 14 every 21 days, and lapitanib in a dose of 1,250 milligrams once daily. And the median treatment duration of all patients was 19 weeks. This is the summary of CNS-related outcomes in selected LEAP participant countries. The preliminary data of this program shows a PFS of 18.7 weeks and a 19.4 weeks in patients with and without brain metastasis, respectively. Also, in patients with brain metastasis, brain response was synchronized with systemic responses, and overall survival was 49 weeks and 64.6 weeks in patients with and without brain metastasis, respectively. In conclusion, brain metastasis developed more frequently in HER2-positive breast cancer patients. Trastuzumab was associated with high incidence of brain metastasis in HER2 metastatic breast cancer patients compared to the metastatic breast cancer population, and continuous suppression of HER2 after brain metastasis probably improved the survival, however, leading to more brain metastasis. So the early use of lapitanib may reduce or at least postpone the occurrence of CNS metastasis. It might be worthwhile to consider an early use of lapitanib-based regimen within a framework of a preventive strategy. We were involved in a phase 2 trial to assess the effect of prophylactic cranial irradiation in high-risk cancer patients, and the preliminary data of this trial was presented in the last ESMO meeting. Thank you for your attention. Thank you very much.
Thank you, Professor Tarek Hashim, for this elegant presentation, and we will